David, welcome to Australia.
Thank you. I'm really happy to be here.
And we're very happy to have you.
Thank you.
I think it's important for our country and for the assisted dying cause to hear the experiences from a medical professional who's been involved in the care. He's walked the walk for many years.
Well, I'm happy to share my experiences with you, and thank you for the invitation.
Can I start by asking a little bit about your background?
Sure. Yeah. Well, I'm a family physician, retired family physician. I retired a couple of years ago. I practiced in a very small town in Oregon, a town of about 2,000 when I went there. I was about 4,000 when I retired. It wasn't all my fault that there was more people there. And I did a full gamut of medicine. I delivered babies. I did all the hospital care for my patients. Not all of it, but most of it. Did minor surgery in the office. It was a two-person office when we began. By the time I retired, there was 5 of us. I was there for 35 years in the same little town in Oregon, and it was a great experience. I just miss it a lot in so many ways.
So you were a real doctor?
Well, I think so, yeah.
What we would call in Australia a rural GP.
Yeah. And I did do a lot of end-of-life care as a consequence. I mean, that's what we do.
Yeah.
We deliver babies, but we take care of end-of-life patients.
So from the cradle to the grave.
Absolutely.
So what was it like for you as a practicing busy physician right at the coalface at the time where the law came in?
You mean the first case? Is that what you were requesting?
I'm going to get to the first case, but what I'm really asking is what was your feelings towards the legislation which would then empower you to be able to give patient that choice?
I would have to say ambivalent.
So your first thoughts were ambivalent?
Yes, I knew that there was a lot of activists and a lot of people who were wanting this and that they pushed it through. And I don't really remember, but I think I voted in favor of it, but I can't even remember that.
Right.
I didn't think about it much more than that until that first patient came to me. So
tell me about that.
Well, it was in 1999, and I remember him well. He had terminal liver cancer. When he was first diagnosed, it was late. He came to me with abdominal pain. I did a scan and referred him to a subspecialist.
What age was he?
He was in his 40s.
Okay. So young man.
This is an engineer, a very, as all engineers seem to be. I have a brother who's an engineer. He knew what he wanted. He knew it was black and white. This is what I'm going to do. This is what I'm not going to do. He was not wishy-washy from day one about if he wanted this kind of treatment. He kept records and charts about all of his visits. But sadly, he had a terminal diagnosis from the beginning, and he went downhill fairly quickly. He came in and asked me about that, and I didn't know what to do.
So he initiated the conversation about assisted dying.
Yeah, almost always that's the case.
What was your reaction?
Confusion and wondering. I hadn't done this before. I talked to my practice partner, and very blessedly, our hospice medical director, a wonderful man that I'd worked with in hospices since 1980, so almost 20 years already. I went and had tea with him, and I met with him a few times, and he mentored me through the process, which is not difficult or complicated, but it's pretty deep. You have to think about what your own priorities and values are. You have to remember who you are, that you're their doctor. They're the one with the disease, yes. and you take care of them. He helped me realize the kinds of palliative questions that we now have formally developed in the palliative care field. And then he became the consulting physician. So in Oregon, we needed 2 doctors. And so I was the attending physician, and he helped me, sort of held my hand through that process, and I wrote a prescription. I offered to attend the death, but the patient did not want that. He's a very private person, wanted to be just with he and his wife. He had no children. And he had a very gentle death, prescribed at that time a medication called pentobarbital, which he was able to take. And
it was a tablet or a syrup or something?
It was a powder. It came in a powder. You just mixed it up with 4 ounces of water.
Right. Okay.
Nembutal. I don't know if you had that name here.
Yeah, we have the name Nembutal. So Would it be fair to say that your reaction was, after due consideration, that your reaction was that at the end of the day, it was the patient who mattered? So
absolutely.
The decision was not yours. You were there to facilitate, but it was the patient.
Absolutely. I think that's the most important thing for us physicians to remember. We have a lot of training, we have experience, we can guide and assist and help and teach, but the patient is the one who has the problem, and their choice of how to deal with that problem should be paramount in all of our relationships with them.
So have you had patients where you've had that conversation and they've chosen not to have an assisted dying?
The majority of people, I would say. If you look at the statistics in Oregon, and they've been kept now for many, many, many years, many people want to have the conversation, and it's not even measurable, so many people want to talk about it, even when they're not sick. They want to say, hey doctor, what do you think about aid in dying or voluntary assisted dying? And they don't have any diseases, they just want to know what kind of a doctor you are, because your answer to them is really impacts the relationship in where you are in other conversations.
Yeah.
But a vast majority of people begin the conversation, a few of them, and particularly in terminally ill patients. Then a few of them might kind of want to go to the next step, and a fewer number even still won't begin the process. Unfortunately and sadly, many of them die in the process because there are steps that are so-called safety measures that turn out to be barriers. And then ultimately, at the end of the day, a very, very few people would do this. So in my practice, for example, ultimately, one or two a year will ultimately go through the whole process. And then, surprising to so many people, only 2/3 of people take the medicine, even though they have the pill bottle in their hand.
Why is that?
They're empowered to be in control. It's palliative. Just the conversation, just having the prescription there, may be all that they want. They now have control over this, the last few days, the end of their story, and their stories really matter to them.
David, from your experience and that of your colleagues and the literature, I'd like you to answer this question. Opponents, particularly medical opponents to assisted dying, make a claim that the doctors who will participate in assisted dying, it will negatively affect the relationship between the patient and the doctor.
Yes, that's an argument that's made. It's absolutely, in my opinion, completely false, and I think just the opposite is true. In my experience, if you go to the doctor and she or he has a shared conversation with you about all opportunities and possibilities, you can trust them to know that they're in your working for you. When you confront, or a patient confronts you as a physician about any topic, whether it's birth control pills or voluntary assisted dying or whatever, and you say, oh, I don't do that, talk to somebody else, nope, and which unfortunately, even in Oregon, too often happens, that is what's harmful to the doctor-patient relationship. The doctor-patient relationship is based on trust, and when your doctor can talk to you about anything, that's the doctor that you can trust.
And are you aware of any international evidence that the conversation itself or the knowledge that a doctor actually participates in end-of-life care negatively affects the doctor-patient relationship going forward?
No, there are rumors of this, and I've been in conversations and debates with other doctors that's been presented, and I've always asked, can you show me research that shows that? Undoubtedly, there must be the occasional case, really. But I think we as physicians who are loving and caring people and want the best for our patients and not to see them suffer should be professional enough to be comfortable in many difficult situations. It isn't just VAD, but you're taking care of many terrible other cases. And some of us doctors do get impacted by those hard cases. I know that that's true. And that we need to do things to prepare ourselves to be healthy.
I want to talk a little bit about that, because there's a claim from our opponents also in this country that doctors who participate in end-of-life care, that includes assisted dying, suffer emotionally or psychologically as a result. Are you aware of any of that?
No, I'm not, and I never personally felt that, and I had a number of peers in my community, my practice partner, and then ultimately other practice partners and people that I've known. I've worked in the hospice arena for almost 40 years now, and I've not known that. I hear it, but I don't see it, and I look for it to try to find out if that seems to be the case. I've never actually, to be quite honest with you, David, ever encountered one case of a doctor who had was struggling after helping their patient consider this option.
My response is that it's actually the opposite, that cases that I've been involved in and continue to be involved in where there's been a bad death, bad death defined as unnecessary suffering of the patient and family, because the option wasn't available or because of unsuccessful palliative care, those are the cases that stay with me.
I agree with you 100%. Absolutely true. Yeah, those are the ones. Yeah.
I also want to talk about the process. So before we were talking about a case that you were talking about where it was what you called a beautiful death. Could you take me through it? And then after that, I want to contrast that with cases where people have taken the law into their own hands, as it were, and ended their life, and contrast the effect of that on the families.
Well, I might tell a case of Ben and Pam Wald, and I have permission from Pam, the widow, and that family, other members in their family, to tell the story.
I think it's a well-documented case in the literature.
But Ben was my patient, and he was dying of colon cancer. He started out 200 pounds. He was weighed almost 100 pounds when he died. He'd been through all the treatments. He'd had surgery. He'd had chemo. He'd had radiation. Subsequently, it wasn't working. His wife was interesting. His wife was Catholic and was opposed to his choice for aid in dying, but was supportive of it, even though in her heart she didn't really want him to do this. Of course, she loved him. She didn't want him to go. We met. Went through the procedure. Another doctor met, and I did a house call for him. And fortunately, a cancer specialist came and did the house call too. Went through the waiting period. He got the prescription. They set a date. They had friends over. They all had ate together, although Ben could not eat at that time. Then they individually met with Ben in private session. He was a counselor, by the way, and some of those people have told me that his final words to them were extraordinarily powerful and meaningful. Then she got in bed with him, and according, I was not there. I said I would be, but they didn't want me to be there, which is fine. And the hospice nurse was there, and as were a couple other helping people. And Pam had told me later that it was beautiful. He said thank you as his last words. He drank his medication, put his hands across his chest, as he always did when he was relaxed, and gently fell asleep. They had their own music on, they had candles, and Pam describes it really as almost a sacred death. And then she realized, interesting, afterwards, that this was the best thing she could have ever done for him. And it was her ultimate gift of love to him. So that's would be not untypical. And I have attended a few planned deaths. I attended a planned death a couple months ago, similar, with a woman, and she had 7 of her grandchildren in the room, and one of her 2 children, her other child, was sick. And it was, again, just calm, peaceful, gentle, kind thing. It was really sacred. You know, I lived a lot of babies, and you always talk about the miracle of birth. But I would have to say it was almost like the miracle of death. It was just, I could say beautiful.
Peaceful and calm.
Yeah, yeah.
Can I then ask you about some suicides that cases that you've been involved in? And I use the term deliberately and differently, where patients have not used the assisted dying laws and they've taken their lives through non-medically assisted ways, often violent ways. You alluded to one before we came on camera. Can you please compare the effects of those deaths with the assisted dying deaths on the families?
Yeah, it's totally different, and I think the language matters a lot. And in medicine, we use language appropriately, or try to use language appropriately, and that's why we don't use the word suicide. not to make it sweet or nice or anything, but because we understand the huge difference between what a suicide is and what a medical aid in dying is, and they're totally different. And also, I think it's really, really important in end-of-life care to use language that does not cause fear or anxiety or guilt or particularly shame.
I call it polluting the argument.
Yeah, it's hurtful. And if you're a compassionate and caring doctor, you don't use hurtful language.
Of course.
But it's completely different. Unfortunately, before our aid in dying law passed, I had a case, and this is also a case I can talk about publicly because the family's given me this permission after they had some difficulties for a number of years about his death. But this is a neighbor of mine who was dying of bladder cancer, and he was in hospice, and I thought was getting as much as we could do in those days for him. And I was asked to come and see him because his son thought something was wrong. His son was home. He was a neighbor. I went there, and he had taken his life with a shotgun. I was the one that uncovered that. It was the exact opposite of Ben Wald's death. There could be nothing. He was alone. It was impulsive. It was violent. The physical destruction, not only of the bedroom, but of all his body is indescribable. The guilt that his family felt, that I wasn't his doctor, but that I felt because he was my neighbor and sort of a friend, and his doctor all felt afterwards is different. The grieving reaction in the two cases, VAD versus suicide, is totally different. In VAD cases, you'll see, Western Australia will learn that it's normal. Their sadness, where the loved one is gone, there's a hole in our heart missing that person, but they're not suffering anymore, and they had a chapter in their book that ended their life in a good way. In the suicidal case, we were all wondering what we could have done.
And not to mention that his teenage son discovered him.
Yeah, I can't imagine how that would have been, and I have talked to him subsequently. I don't think that the teenage son has still processed the whole thing. It's hard for him to talk about that even 20 years later.
Compare that, though, to the long-term experience of family members who survived, who witnessed an assisted dying death. What are they like 5, 10, 15 years down the line?
I have to say grateful. They're so grateful that their loved one had an ending to their life that was what they wanted, that their suffering ended in a peaceful way. And I still get thanks and thank you cards from these people. If I see them in the store, they'll say, doctor, thank you. And it's just completely different.
I think this is a really powerful point that is perhaps oft missed and would only be brought out by people such as yourself, who get to witness the aftermath in both cases. And we know in Australia that, at least in the Victorian experience, about one person per week in Victoria kills themselves when approaching this sort of thing. So patients are actually doing this already. We know that from the Victorian coroner's testimony and also the South Australian coroner's testimony. Can I talk a little bit about palliative care,
Sure.
Please? Because it is often claimed by some of my doctor colleagues, but also politicians, that just send them to palliative care, they'll look after them, they do a great job.
They do, and I agree. We should send all these patients to palliative care, and I always, I can't demand that, but I would encourage these people, and I think that's probably part of your laws in Victoria and the proposals in Western Australia, certainly in the Oregon law, that all of these individuals should be sent for palliative care programs. I'm a huge palliative care guy and hospice guy. I just think it's so wonderful the help that they can provide. This voluntary assisted dying is a component in Oregon of palliative care. It's just a part of the process. It's not other, it's not different. It's an option, something to talk about. Very few people choose. However, the benefit of VAD for palliative care programs is just talking about VAD is palliative in and of itself. Just having that full conversation about all choices at end of life is relieving. I've been through this so many times where when the patient says to me, well, doctor, what about death with dignity? That's what we call it in Oregon. And I say, okay, let's talk about it. It's just this relief in their face, in their body movements that really we can talk about this. And that's palliative, and it's part of palliative medicine. But yes, I think I agree with that person who says, send them to palliative care. Palliative care is really wonderful. Sadly, not 100% of the time can palliative care teams relieve terminal suffering. And that's the enemy here, is terminal suffering. That suffering near the very end of life that the patient defines, that is not solved by any of the things that we and our wonderful palliative care doctors can do.
Can you tell me a little bit more about that? This is a really important issue for us. I regard palliative care as a treating physician exactly the same as you do. They're my colleagues, and like every other medical specialty, they have their place. They also have their cases where they're going to be unsuccessful. Occasionally I've met patients who don't want to be referred to palliative care for one reason or another, despite adequate disclosure about what palliative care can offer.
Right.
They're the minority, I have to say. But tell me about cases where the minority, where palliative care isn't successful, isn't able to relieve suffering, and the patient is left trapped.
Well, there are too many of those because, well, you know, if there's, we're all going to die, and so there are many, many stories to be told. But I've had conversations with palliative care doctors who disagreed that aid in dying should be an option. And one example that I would provide, if I could be a little graphic, but I would have to be at times, was a woman who was not a patient of mine, but was a patient of a peer of mine in a nearby community, who had a vaginal cancer. And so she had been through surgery, she had been through chemotherapy and radiation. Wonderful things to help her for a while, but the consequences of those treatments gave her fistulas, which are connections between the vagina, the colon, and the bladder.
And the skin.
So she was then having discharges of the biological products that were terrible. We couldn't handle all these things. And she felt like she had the flu all the time because of the chronic inflammation that she was having. So she kind of felt sick all the time. She had a lot of pain, but the biggest problem were the discharges and the consequent odors. She did not want her grandchildren to visit her.
Right.
I can't imagine that. I have 7 grandchildren, 5 grandchildren. I don't know how many grandchildren I have, but it's unimaginable that we'd be in a situation where you couldn't have your grandchildren come to visit you, because nothing that the palliative care team could come up with could resolve all of these symptoms, not just physical, but other things too. And so she was a woman who chose aid in dying, and had then a peaceful death. But her last months before she chose that were about as bad as anything I've ever seen.
Horrific, yeah, and I've had experiences similar to that. So in your experience, what are the major factors that will affect patients' choice in selecting aid in dying in terms of symptoms or background factors?
Yeah, it's fascinating because everybody says, well, we can control the pain, right? But it's not about pain. That's, if you look at the Oregon statistics, that's generally the 5th or 6th or 7th reason people choose this. The number one reason is autonomy. They are going to die. It's going to happen in a few days or weeks, and they want to have some control over that. They have control over nothing else. They want to make a choice. They want to be in control. There's a particular personality type of people who choose this. They aren't being forced into this. This is something they've known about for a long time. It's another thing that we could talk about is that this doesn't just come up willy-nilly. The conversations have been going on for quite a while.
I'm definitely going to get to that, but I'm really interested for you to tell me about the symptoms and the types of people and that want assisted dying, and why pain is not the main factor.
Well, one of the reasons that it's not the main factor, I think, is what we've just said. Palliative care programs are fantastic, and they can really come up with new ideas. We can't control all pain, but we can do a much better job than we did even just a few years ago. The second reason is loss of dignity. And loss of dignity, again, like like suffering, who defines dignity? I don't define your dignity, David. You define it. And something that you feels very undignified, I might think is fine. I could wear a purple shirt and think it's great, and you might think that you'd never be seen in that.
One, right?
Yeah. So loss of dignity, and that includes such things as having someone else having to clean you up after you've had a mistake, loss of continence of your bladder or your bowels,
or your lady with the vaginal cancer,
or the odors that are occurring. So those are the top two. The third one then is anhedonia, which is a big word for lack of pleasure. There's nothing in your life that has any, it's different than depression. There's not one thing in your day-to-day as you're dying
gives you any pleasure.
There's not a single thing that you can see, and that seems to come in, high on the list.
Those people depressed.
I think it's different than depression. If you look at they're having a grief reaction. Huge difference between depression and a grief reaction.
Right.
We could go through all the points about that. They're sad. Their family is sad. Their doctor is sad. That doesn't change the fact that they're about to die, whether they're sad or happy. Most people wouldn't be happy that they're about to die, in fact.
So this sadness is not depression, not clinical depression.
It's a grief reaction.
It's a grief reaction. It's a adjustment, if we can say. Is it able to be treated with medication?
No, it's not really being able to be treated. Fortunately, we have a number of medications and other options now in medicine that really do help with depression. And I saw that in my practice, because when I began in practice, there weren't some of these new selective serotonin reuptake inhibitors and things. But they make no difference here. That isn't going to change your loss of dignity, your anhedonia, your autonomy. There's no medicines for autonomy. That's something that comes from yourself.
Are you aware of cases yourself or through the literature where patients have been coerced into selecting assisted dying?
It's a great question, David, and the answer is no. I've never heard of it, and it doesn't, we could look and try to find those cases. Here's a really important point to bring out. In Oregon, almost 19 out of 20, about 90, just a little bit less than 95% of patients who choose voluntary assisted dying are in hospice. If they're in hospice, they have visits on a regular basis by the hospice nurse, the bath aide, the social worker, the chaplain, sometimes the medical director, their own family doctor. And if there's coercion, it's discoverable, because these people aren't off somewhere that we don't know what's going on in their life. We know they're very connected, they're part of the system. So coercion, no, there isn't. Also really important to bring up, and we haven't talked about this, is that the disabled are not, there's never been any evidence that this group, and I don't know why in the US, but somehow some of the disabled groups have gotten a message that they're at risk for this. And I understand why disabled groups, and I am sad about it, that we haven't treated them with more dignity and better services that we have historically. But there's no evidence that minorities, people of color, the poor, the groups of anyone has had abuse. In fact, the head of disability rights in Oregon, the chair of the organization, which is a nonprofit for them, writes yearly a letter stating that there's not been evidence in his organization regarding abuse of aid in dying.
Because this is one of the biggest concerns of politicians in this country and others, where it would be an easy path to push someone down for a relative, let's say, who stands to benefit from their death.
It's not an easy path. It's nigh on impossible. And again, the safeguards that your new laws propose and that we have had in Oregon for 22 years never have shown it. So something to be aware of. I agree, we should always be careful. We wouldn't want that to be.
But in your 22 years of experience with it, to date, there's not been cases. In fact, would it be fair to say, from my reading of the literature and my experience here as a doctor where it's not legal, is that if you were a relative where you wanted to do that, it would be detrimental to subject that relative to an open, transparent, state-sponsored process if you wanted to coerce them. Because you'd want to be doing it quietly in the dark, I think.
Yeah, and in those evil places, I'm sure that would happen, and I hate to think of that it's true, but we do know, sadly, that there is domestic violence and elder abuse, and those are sad areas, but not in arenas such as voluntary assisted dying. That's not where that would occur.
So in your view, David, there's no slippery slope?
There's no slippery slope with death with dignity in Oregon or in the other authorized states. We've not seen that, and there won't be a slippery slope, I don't believe, in Victoria and in Western Australia. There's no slippery slope that aid in dying is the first sign of a Soylent Green kind of a situation. It's never happened anywhere. Our Oregon law was made 22 years ago now. Has been solid. There's not been changes. There was a change a couple weeks ago in it for the very first time. Yeah. But otherwise, it's not happening. We don't see it.
What was that change?
Well, when we came up with our law 22 years ago, we had this waiting period of a couple weeks that's going to be in your laws, which we thought was very necessary to prevent impulsivity and thorough understanding of the patient's problems and understanding of their wishes. Turns out that waiting period resulted in many people dying before they could get through the process. Some would guesstimate that half of the people who begin the process don't even get through it. So because all of these people, as I've just told you, are in hospice, they've talked about it forever, we realize the waiting period isn't necessary. They've already done the waiting period, for the last 6 months during their unsuccessful treatments. So it's been changed to 2 days. Right. And I think that was a really good change, because I was recognizing too that the process of all this waiting wasn't changing their desire or wishes, but it was causing them to suffer more.
And apart from the fact that they're dying, my understanding of the Oregon statistics, please correct me if I'm wrong, is that these people are not necessarily what you would call a vulnerable group, except they're dying. So they tend to be better educated, a bit more affluent, well supported. White, I think, is a predominant subgroup. Mm-hmm. Is that correct?
It's correct not only in Oregon, but in other states that have statistics, like Washington, which has over 10 years of statistics, and the new statistics coming out of California over the last couple of years. Absolutely true.
So they're not people who are under hardship financially or illiterate or without relatives. They tend to be people who are what we would otherwise call well supported and quite competent.
Absolutely.
It may be a case that a lot of our colleagues will never be involved in end-of-life care. And those who are, the primary care physicians, perhaps the oncologists and palliative care physicians, are at the coalface. Mm-hmm. And can you talk a little bit about, in your state, how the type of specialty can govern how you respond to these types of cases?
I think it matters a lot, David, that we talk about this, because it's taking care of a dying person is an honor, but it takes a lot of skill, and experience helps too. And I think I did a much better job near the end of my career than I did at the beginning. But so many doctors don't have that the education and the experience of this, particularly the super subspecialties. But I don't want to particularly name any exactly. But in family medicine, in gerontology, in oncology, now in neurology, in particular, we understand the intricacies and the complexities that occur in someone who's dying. And even as doctors, if you don't take care of dying patients, you really don't understand all these complexities. So I think that's a really good point to bring up. In America, for example, the subspecialties that handle these things, like the hospice and palliative care subspecialties, I think you call them Royal Colleges here in Australia, the Academy of Family Physicians in the U.S., these all now have gone to a position of neutrality. We are not opposed to aid in dying or death with dignity in the United States. The global organization of medicine in the United States still has resistance to that change. But it's interesting to watch. The American Nurses Association, which is very important, as we know as doctors that we can't do anything without good nursing care, has now just recently in July moved to a neutrality position from opposition. And so we're seeing this happen as people become familiar with it.
Well, perhaps we're ahead of you on that regard, because the Australian Nurses and Midwives Association has been pro-assisted dying for some years now. Much to our pleasure. Can I ask you a little bit about why you think that your organisation, the AMA, the American Medical Association, and our Australian Medical Association are treating this particular issue in a non-evidence-based way and a non-patient-focused way?
Wow, I wish I could answer that question better, because I don't quite understand it. I've just been, as I mentioned, in Chicago at the AMA meetings and spoke with many of our doctor colleagues and peers there. I don't understand if it's based on history. This is the way that it's always been. I certainly know that it's the American Medical Association has had difficulty with change in other arenas. I think there's this feeling that we are there as, in quote, healers, and it's an interesting tension between someone who has a few days to live, what healing means to them, and what I as a doctor think healing means. I think it means you're not going to die on my watch. And they're thinking, you could heal me by offering me some choices and answers to help with my suffering. But I'm not going to be able to give you a very good answer, because I don't get it either.
Okay, yeah. Well, I'm glad that makes two of us. Yeah. So can we just talk a little bit about the idea of imminently dying, and whether you keeping me alive is or not is causing harm or not? Because it's my view with some of my patients where they're intolerably suffering. Let's use your lady with the vaginal cancer as an example. That keeping them alive, or at least not allowing them to take their own life using our assisted dying, that is causing harm.
Well, we've come now to the third word that we confuse, and we talked about who defines suffering, and we talked about who defines dignity. Well, who defines harm?
Right.
Historically, it's been me, the doctor. You know, primum non nocere is a tenet we learned early on in medical school. Don't do any harm. But it was defined by us. Like, we know what the harm is, and we're not going to do it. Not thinking that perhaps what we're doing to someone, their interpretation of that is not the same as ours. Harm needs to be defined by the patient.
So we've got a patient who is suffering. We are, in this country at the moment, aside from Victoria, not giving them that option. So me as a doctor, I'm walking forward with one option not available to me. And we are acknowledging that palliative care sometimes, unfortunately and sadly, can't address those major key issues that you, in your experience, see patients choosing. So aren't we then, in our situation, trapping patients into a vortex where they are being forced to suffer without an available option open to them?
Well, that's what I believe. And that's why I believe that death with dignity is of great value in Oregon, and the VAD new acts and bills and laws in Australia would be beneficial, not only for the dying person, which is most important after all, but for your whole system and for your palliative care programs.
How do you in Oregon deal with some of our colleagues who don't want to participate in end of life, at least assisted dying?
Yeah, so it's a mixed bag, and there's 100 million different ways to answer that question. Biggest answer is not very well. If a doctor in Oregon, according to our law, chooses not to participate, that's the end of it. They don't have to do anything. There is a rule that they have to send medical records within 30 days. That sounds like a good rule, except 30 days for someone who has a week or two is not soon enough. So we don't have any way that we can force a physician. Furthermore, we have actually systems that block doctors participating, and so they can't do anything. If their office is owned by the Catholic Church, for example, they're not allowed to talk about this with their patient, even if they would like to, or refer to someone else who might talk about it with them. So there's a lot. We still have pockets of problems in our state. We also have on the other side of the coin where it's much more normalized. and all of our non-Catholic hospices have engaged neutrality now. That means they support the patient and will help them make the choice that the patient wants. And so in the way that I think a professional physician would act, as I mentioned to you, would be to, if I conscientiously object to this, would be refer to another person to evaluate the patient and discuss what their choices were.
Have you seen amongst your colleagues over the time that you've been involved with this, cases where the doctors who were initially against assisted dying come around to the idea?
Absolutely, it happens.
Can you tell me a little bit about that?
Well, we have a phrase we call that one case, and it may be a doctor who's either ambivalent or opposed to aid in dying and always has had that opinion, has cared for an individual for 20 years, and they've been through the wars, the ups and the downs, and the thises and the that's, and then that person gets a terminal cancer, let's say pancreatic cancer, and says that they would like to have aid in dying. And this doctor loves them so much that he or she cannot say no, and go through the process, get mentored, and then realize it was a gift that they were able to provide the patient. It changes them, and I've seen that again and again and again.
Okay.
Maybe it was me.
Yeah. You keep using this word gift, and I like that. I call it an act of love in a professionally boundaried way. And we talked about this a little earlier, where the language, and you talked about language, where the language used we need to be very careful of, and our opponents talk about state-sponsored killing and lethal injections and things. I've had a situation where a state member of parliament talked about state-sponsored killing to me, and that we don't want our state to sanction state-sponsored killing. And I was saying to him, listen, when you're in the situation of patients like you talk about, we want the state to give the patient the option. And I call it an act of love. You call it a gift, right? So it's not sanctioning state-sponsored killing, is it? It's giving the patient autonomy, giving them a way through these symptoms that are unrelievable, and in a way it's an acknowledgement and an act of compassion by the state.
Yeah, and it is disturbing to me when we have the conversation about this topic that people get use language that is hurtful or shameful or causes guilt. It tells me they really haven't been at the bedside of a dying person. Could they possibly, when holding the hand of their dying patient, say to them, "Oh, don't do this, this is suicide"? Could they use that language to that person? This is state-sponsored killing. If they did, I think that's totally unprofessional. We need to talk with one another in kind language as well, not just about this topic, not just to our dying patients.
I want to ask you about this concept of burden, and that some of the opponents to assisted dying laws claim that patients want to use it so that they're not a burden, and that burden can be relieved by palliative care. Can you speak to that a little bit about your experience with these patients?
Sure. Well, as I mentioned before, a good palliative care doctor, family doctor, or anyone taking care of the dying person should investigate all the reasons that the patient is inquiring about this, including is that topic, either bring it up or hear it if they say it. But I think when we talk about burden, it's all about context. You can't take it out and separate it from the pancreatic cancer, the financial situation of the family, the past history, the backstory for the loved ones, and it all gets mixed in there. And so separating it out and saying, oh, well, burden, I don't want to be a burden, that's no reason to use it. It is not possible to separate it out. So to me, it's just one of the many complexities, and it's a cofactor, but it isn't something we should separate. Say we can't have this law because people would use it because they're feeling it's a burden. It's never one thing like that.
So do patients say to you, I want to die because I feel like I'm too much of a burden to people?
Yes, they might. Yep. And then I would ask them, why do you say it? What I hear you saying, active listening. flush it out and figure out what it might be. Talk with the family and that patient together in a triad and say, Mom says she might be a burden. What do you think about that? And have that conversation. It never turns out to be the main reason that the intolerable suffering. Right. It's a part of it.
I see what you're saying. Okay. I just want to get some final comments from you and ask from your experience what advice you would give to Australian doctors and to Australian politicians who are either undecided or haven't made themselves acquainted with the process and the international evidence. What advice would you give to those people?
Well, I feel so welcomed here in Australia. My first thing to say would be I would invite them to come to Oregon and visit and see what our hospice and palliative and end-of-life care programs are about. They would not find them weird or strange. I think they would find them beautiful and wonderful and complete. And so first thing I would say is if you came to Oregon, there would be nothing that would be bothersome to you about the fact that we have this option. The second thing I would say would be to remind ourselves it's not about us. And we get so bothered by this. I think Atul Gawande said, we worry about autonomy for ourselves, but safety for others. And we need to remind ourselves that we need to worry about autonomy for others also. And I guess the last thing, which I think is most important of all, since we've had our Death with Dignity VAD law in Oregon for now 22 years, more people have not died, but fewer people have suffered. In other words, everybody who chose them was about to die. So the fact that they died a week or two before or after is not what mattered. They didn't suffer. And to me, that's the greatest value.
David, I want to thank you for your coming all this way
You're very kind.
to Australia, and it's been an absolute pleasure.
Thank you.